Hello one and all, today we're going to discuss about a case study which is really interesting, that is osteoarthritis, a physiotherapy perspective. So introduction, what is osteoarthritis? So chronic degenerative joint disease, it affects cartilage, bone and synovium. It is progressive and non-inflammatory initially. And what are the types of osteoarthritis? Is primary, that is idiopathic, unknown reason, whereas secondary due to trauma, obesity, metabolic disorders and all, whereas other forms includes erosive and nodal. What could be the epidemiology and risk factors? So it is common in people over 50 years. Women are more prone than men. The risk factors include obesity, genetics, joint injury and sedentary lifestyle. So pathophysiology, it could be either because of cartilage breakdown, subchondral bone sclerosis, osteophyte formation, synovial inflammation. Calligren and Lawrence grading include grading 0 is normal, grading 1 includes doubtful narrowing, grade 2 is definite osteophytes, whereas 3 is moderate space loss, whereas 4 is severe changes in the knee joint. Yeah, this is nothing but a patient which I have been seeing. So he is aged under 62 years. His gender is male, and he is a retired teacher with a history of hypertension for 10 years and osteoarthritis for 5 years. His chief complaint is knee pain and joint stiffness. Yeah, the main chief complaint is bilateral knee pain, morning stiffness, and he has a difficulty in stair climbing, and he has been complaining of a decreased walking tolerance. So while history taking, there is no history of trauma, and the onset is gradual, and the swelling is very occasional, and no fever or redness. His lifestyle is very sedentary. His BMI is about 29, and he lives independently, no assistive devices. On observation and inspection, there was mild varus deformity and joint swelling and muscle atrophy. That is, especially quadriceps muscle atrophy was present. And during palpation, tenderness at the medial joint line was present, and crepitus on movement, and positive patellar tap test was present. Yes, during range of motion, there was a limited flexion to 90 degree, and extension was normal, and infield was hard. And during functional assessment, that is timed up go, that is tuck test was about 15 seconds, and 6-minute walk test took about 280 meters, and difficulty with sit to stand. His x-rays exhibited joint space narrowing and osteophytes, whereas blood, there was normal CPR and ESR. During diagnosis, osteoarthritis grade 2, that is Calligren and Lawrence grading, bilateral knees, and based on clinical and radiological findings, diagnosis was concluded. And right now the problem list is pain, limited ROA, muscle weakness, gait dysfunction, reduced ADL participation. And right now my short-term goal was to reduce pain and improve ROM, whereas long-term goal was to improve strength and delay progression. And the treatment phases, during acute phase, pain control, during subacute, restore ROM, and during chronic, strength and function. Yeah, coming to the multidisciplinary management, orthopedic consultant was done, and dietitian for weight loss management, and pain specialist, that is myself. Yeah. Pain relief strategies, that is cryotherapy and TENS, and manual therapy, that is soft tissue mobilization has been given to him, and ROM and mobility exercise. Initially we were doing a passive ROM exercise, and gradually improved to active assisted ROM, and heel slides and wall squats have been performed. And during strengthening exercise, isometrics further, that is progress to isotonics, especially the focus was on quadriceps and hamstring. Especially in quadriceps, the focus was on VMO, and leg press and mini squats has also been given. And balance and proprioception, tandem stance, wobble board has been given. Dynamic reaching test task has also been given. And during gait training session, cane has been given to the opposite side, and step training and weight bearing retraining has also been given. And during functional training, sit to stand, stair climbing, bed mobility and transfers has been given to him. And during home program, daily ROM and strength routine has been prescribed. Initially he was advised to avoid squatting and kneeling, and 30 minutes of walking with rest have been advised. And lifestyle modification with the help of multidisciplinary team, weight control, ergonomic advice, and joint protection principles has been educated. So outcome measures, I've been using a visual analog scale. The pain has been reduced from 7 to 3, and in ROM 90 degree to 115 degree, the range has been increased. And muscle power, initially it was 3, gradually it been increased to 4, and improved tug and 6-minute walk test scores. Yeah.